introduce our speakers, starting with Dr. Sam Lau. Dr. Lau is Professor Emeritus at University of Florida. We were just chatting about the College Baseball World Series, College of Dentistry, and has 30 years of private practice experience in periodontics, lasers, and implant placement. He is the immediate past president of the Academy of Laser Dentistry and past president of the American Academy of Periodontology. He's accepted multiple industry awards through the years, including Dentist of the Year by the Florida Dental Association, Distinguished Alumnus by the University of Texas Dental School, and the Gordon Christensen Lecture Recognition Award. And then we have Dr. Todd Jorgenson. He is founder and chief executive officer of Arizona Implant and Periodontal Centers. Recognized by his peers as a leader in his field of practice over the last 2 decades, he is currently the periodontist for the Phoenix Suns and Arizona Diamondbacks. So Dr. Jorgenson holds an MBA from Yale University, a doctoral of dental medicine degree from Oregon Health Sciences University, and he also holds degrees from Oklahoma and Utah State. And he's coming in from Hawaii, so he's soaking in some sunshine out in Hawaii with us this evening. So with that, I believe Dr. Lau is going to kick things off, and I will hand it over to you, Dr. Lau.
Well, thank you, Joe, and it is a real treat to be with some of you today, and also to bring in, from a clinical standpoint, Todd Jorgenson, who probably has performed more implantitis cases with laser than possibly anyone in the world. And we're going to really sort of delve into his expertise and really get some pearls for what we can do about this thing, about the sick implant. I don't know about you, but just about every day I see someone talking about implantitis. And it is approaching almost what I would consider to be an epidemic proportion. And there's several reasons for the increased incidence of it. But more importantly, when we use the word sick, it is one of those issues to where when we place an implant, the only other resolution that we have is if it does get implantitis that we have to deal with it, we either have to manage it or we have to take it out and start over again. And I don't think anyone on this webinar wants to take an implant out unless we just have to. But we're going to talk about that a little bit. So when Todd and I look at this webinar, we've got sort of 4 things we want to chat with you about. One is you can't manage something if you don't know why it's happening. And we want to look at not just the traditional microbial aspect of it, but also this new metallosis theory about surface corrosion and how the laser may have an factor on that. We also want to take a look, although many of you probably on this webinar have excellent expertise in lasers, we want to clarify just what wavelengths are appropriate for managing implants. Naturally, I think one of the most important things for this webinar is to create a step-by-step workflow in managing implant disease. And I'm definitely going to want to hear from Todd on how he manages workflow and basically when it's based on certain cases, case presentations, etc. And then we want to spend some time with you describing how we interrelate with patients in describing lasers, how we're managing implantitis with it, and just to also consider the fact that this is quite interesting, especially if you're a periodontist. I never would have thought that I would discuss with you that managing implant disease could actually be a value-added revenue stream. And when I suggest that, is that we are now starting to manage the implantitis that are coming in from other healthcare professionals. So managing your own implantitis with the patients that you place implants with is one thing, but we're now starting to see referrals to our practices, especially if you're a periodontist, on managing others' implants. So where are we in 2023? Well, there's an estimate that at least 5 million implants are placed per year in the United States. By the way, when you look at internationally, we're actually sort of behind the curve in the number of implants placed, primarily because it's less expensive in other countries, especially in Europe. It is a $6.5 billion industry. We have always talked about it being implant failure being less than 5%. We're going to question that today. And there is just a significant number of focus now on what it takes to keep an implant, survive an implant. Now, initially, we talked a great deal about cement. And many of us experience this foreign body reaction that you get with cement. However, with now so much screw retained, you rarely ever see that unless it was an implant placed several years ago. However, it's not just as simple as implantitis is implantitis. There are many things. Some of us believe that 50% of implantitis is also due to restorative and has nothing to do with the placement. And you'll notice here that here we have screw issues with percolation. We could go on and on and on about the etiology of implant failure. It could be systemic issues. It could be attached gingiva issues, which has become very predominant lately. It could be the size, the width, the length, the anatomy. But it's quite interesting about who do you blame? Do you blame the person who's placing it? Do you blame the person who's restoring it? Well, maybe how do you blame it when the person restoring it and replacing it is you in the same place? So that is why we talk about surgical errors, etc. You and I both know that there are really two kinds of implant disease out there. The mucositis is managed primarily by our dental hygienists. There is no signs of bone loss. I kind of call it the gingivitis of implant disease. And when one looks at the AAP classification system, it's fairly natural that the definitive etiology is going to be biofilm, smoking, radiation, and possible as diabetes. And when we also talk about oral hygiene, all of us appreciate it's a heck of a lot more difficult to have oral hygiene management for an implant prosthesis than it is for a natural tooth. And so now we're starting to look at more and more ways of how to manage the biofilm around implants, and whether it be soft picks, electric toothbrushes, proxy brushes, interdental brushes, and now the sort of the new kid on the block are all of these power flossers, electric battery operated flossers that are now starting to demonstrate as much of effectiveness in managing biofilms as we do see with the traditional oral hygiene instrumentation. But what about those hygienists? And for the most part, hygienists have been relegated to using these kinds of devices. And I think all of us can appreciate they are fairly ineffective. And in fact, I just saw this data, 60% of hygienists reported using plastic instruments for round dental implants, but only 7% thought that they were effective. And then when we take a look at ultrasonics and the adverse effect it can have on the abutments, unless you're using ceramic, most of us are starting to believe that the primary way to manage implant disease is through air medicinal delivery. Again, using erythritol powder. If you don't know about airflow and EMS, you do need to be able to at least investigate the possibilities. This prosthesis, this is 45 seconds later. So now let's move into really the subject. And the subject is peri-implantitis. As we begin to look at peri-implantitis, there are times that you see over on the left that we have the suppuration and we have the pocket depth. But isn't it interesting? And I, for one, am very intrigued about how this resorption is so different from what we see with periodontitis. Even if you look at the distal of this implant, and then look at the mesial of this implant, and I think you can see my cursor, you never, ever see bone resorption like this in naturally occurring periodontitis. You'll see more like an angular defect, a tight three-wall defect. So why is the resorption so far away from the threads? And I'm going to suggest to you a reason why we think that is the case. So when we look at implantitis, there are several things that we do note. We discuss the cement, attached gingiva. The position of the implant has so much to do relative to the osseous phenotype. The position of the implant too close to others. And I'm sure Todd has seen this to where, we've seen root proximity, but now we're starting to see implant proximity, where two implants are placed so close together that you can barely even restore them. But the bottom line for reason to having a conversation with you is I'm going to say right now, we can't afford to lose an implant. We can't afford to lose it. The backlash in losing it and the sequelae of losing implants are almost catastrophic. And when we look at some of the earlier work by the great Carl Misch, he said you don't just lose one implant. And when it's in a prosthesis, you're losing multiple algorithmic dollars. So it's not just about one implant. So to place an implant in New York, I got this from Scott Fromm, periodontist, Long Island. It's $6,400 to place. Now, if you lose the implant, it's $8,720 to put another implant back in. So to lose one implant and replace it is almost $16,000. When one looks at the etiology of implantitis, it's a little different from mucositis. And what's so striking to us is the most effective etiological factor in implantitis is a history of chronic periodontitis, which tells us that this is very akin to what we call the chronic inflammatory cascade. Along with that, smoking, diabetes, cement, positioning of the implants. And therefore, unfortunately, many of us see these kinds of issues. Attached gingiva issues, placement issues in the upper right, proximity issues in the lower right. I'm not even going to tell you how to describe in the center lower. I'm not sure what was going through that person's head when they placed that implant. But now we begin to see this over and over and over again. And now the situation is this. Everybody has a way of trying to manage implants. It's the same thing as with like dental sensitivity or aphthous herpetic lesions. I mean, you put 5 periodontists in the room, you're going to have 5 different methodologies. And what we're going to try to do is suggest to you that some of these methodologies are also dependent upon the implant surface. Now, the one thing about implants is the devil in the deep blue sea. If I have a machined, like you see in the lower left, I can promise you you'll have very few little biofilm scenarios. However, it's not going to osteointegrate. What you see in the anodized in the upper left, you're going to get fairly good osteointegration. But if you lose any, if you have any resorption, lose any bone, you can imagine that this becomes a nidus or biofilm microbiome accumulation. It's time for us to seriously start thinking about corrosion and about metallosis and the consideration that the titanium oxide coming off of these implants is creating a foreign body reaction. My friends, this is not new. Talk to your orthopedic surgeons. They have been dealing with this for years. And in fact, many of the implants being placed now are now ceramic coated. So this is nothing new to them about corrosion. And with us, it would even be more significant because these are enclosed environments with the orthopedic surgeon. Ours is very much in an open scenario. So let's go traditionally and how we do it, how we've been doing it since the first time we saw implant disease. And probably the most common procedure in managing implant disease is the open flap resective. In other words, reflecting the flap, working with the antibiotics, taking everything under the kitchen sink to try to decontaminate the threads. And this began at least 2 decades ago. And so therefore, as we look at the commonalities in these procedures, everyone has their own way of decontaminating the threads. We're going to suggest that maybe this is not as complex as long as you maintain certain principles that we have in our literature. So look at this: hydrochloric acid, tetracycline, EDTA, hydrogen peroxide, erbium, diode lasers. We've done everything. You haven't lived unless you've done an implantoplasty. It's really fun. Plus, you're exuding all the titanium oxide particulates into the tissues themselves. And so that is beginning to die down. I'm sure many of you in the top drawer of the bracket table have implant brushes. And most data demonstrates that these implant brushes do not get into what I call the pitch of the threads. And that is really the issue. You know, I was thinking the other day, what is implantitis? And implantitis is really almost like furcations on steroids. So we're dealing with one simple little furcation when it comes to periodontal disease. Here we have a circumferential. But our main conversation today is to discuss with you about where lasers may fit in the management of implantitis. And for me personally, and I know for Todd, who has been doing this for probably a good decade, and one of the very first individuals to start using erbium, chromium, YSGG lasers for this procedure, we feel that for the most part, that the erbium, chromium, YSGG laser is able to afford you the 3 areas that we think are very critical. 1, you need to degranulate. 2, you need to detoxify the implant surface. And 3, you need to decorticate if you expect any kind of coagulation or any kind of bone morphogenic protein. However, a laser is not a laser is not a laser. Generally, the folks that are going to watch a webinar are those who are already involved in lasers, like. And you and I both know that of the 4 targets, one being melanin, one being blood, the blue being water, the dotted line being hydroxylapatite, that for the most part, diode lasers cannot be used on implant surfaces unless you want to create significant thermal conductivity. So even if you're doing a second stage recovery, please be extremely careful with an Nd:YAG laser or a diode laser. So for the most part, I don't recommend diode lasers for anything that we do around dental implants, because the chances of creating this thermal adverse event is very, very significant. And in fact, I personally have a protocol for removing an implant that you don't want, actually using a diode laser. But if you're not careful, These are actual SEMs of implants that have been touched with diode and Nd:YAG lasers. You've got to be extremely careful. But what turned me on to lasers and really kind of congealed it, especially in my thinking around using lasers, was this incredible article in International Journal Peri-Restorative by our friends in Japan, Yamamoto, using a canine study in which what you see over on the left with implantitis induced, you see no bone growing in the pitch. But if you look over on the right, where erbium lasers were used for the detoxification, you see the implant you see osteointegration into the bone. This has been followed by Don Clem using erbium YAG lasers and bone grafting, demonstrating excellent results in the repair of implant surfaces. Followed by Ron Nevins in a human histology study using GEM21 membranes, erbium, chromium YCG lasers for detoxification. And with this human histology, you can see over on the right, truly getting osteointegration within the threads. So you must have a laser that has a tip that is thin enough, almost the size of a periodontal probe, to be able to degranulate. But you've got to also have this particular tip. This is unique to BioLace. It is a side-firing tip. It was created to present 10% of the energy going straight down, 90% of the energy going actually into the threads. It has a little handle on it at the top. You can see this to tell you what direction the energy is going into the threads. And if you look at the lower left and right, you can see that this is very tenacious resin cement that's been able to be removed from the implant surface without creating any adverse event. A couple of cases from my colleague, Paul Chung, in McKinney, Texas. We published this last year, and here's an early case. By the way, in the upper right, you are seeing the side-firing tip, but notice how Paul has been able to degranulate the area so well. And then when you look at the radiographs before and after, now this is an early implantitis case, you can see, now this is with osseous grafting and membranes, but you can see the result that we are getting re-osteointegration. But let's step it up to moderate to severe implantitis. And here in the upper left, you see before we do the degranulation. In the upper right, you see after Paul is used, decortication, degranulation, detoxification, using demineralized freeze-dried bone. And you can see that this is a 2-year result with a way of almost a heroic effort in saving an implant. So you're going to hear us continue to talk about the 3 axioms for success here, being you must have quality degranulation, detoxification, and decortication. So that was to set you up so that my friend and colleague, Todd Jorgenson, could take us through some cases, and then he and I will have a dialogue as we're going through this. But he has several cases. Again, I think you told me, Todd, you probably have more, about 15 to 1,600 of these cases out there. So I'm going to operate the slides for you, but Todd, take it over and give us your expertise. You're on mute.
There we go. Welcome, everybody. I see we have people from as far away as Nigeria. That's pretty cool. So Sam and I have known each other about 10 years. I practice in Arizona. And I started noticing, I've been in practice 20 years this year. And I started noticing early in my practice, I was getting a lot of failing implants coming in, almost all of them not placed by me. But there really wasn't much expertise or anywhere else to send these cases. And so I did what we all did early on, which was struggle with how in the world do we instrument these surfaces. And I started with the plastic curettes, knowing for a fact there's no way I'm detoxifying SL active anodized surfaces. I was getting off the big stuff, but I was sure that microscopically I had no chance. So I moved into metal instrumentation, thinking, how can we make these implants any sicker? What do we really have to lose? And then implantectomies, like Sam showed, we've all ground down the implant threads. And I realized this is not a pleasant surgery. I don't like doing surgeries where I hope they're going to work rather than expect them to work. So when we got this tissue laser on the market, I was not the first to jump on it, but I was one of the first to start watching it and reading the literature, talking with Sam. And the only reason I bought the laser was for this protocol. It was to detoxify implants. So I thought I would show a few cases that you may come across in your practices. And I'll start with these older implants. This is a Straumann old tissue level implant. And this one had been in service about 15 years. If your practice is like mine, a lot of your patients do not routinely go back and see the dentist for twice a year cleanings. They have no symptoms really. They may notice some taste, they may notice some suppuration, but typically they're told by their dentist, and it's news to them, that their implants are starting to fail. They come back and see me and they're confused, and it's just like Sam showed on the slide with the $8,700 implant replacement. It is a really big hurdle for patients to hear they've got to have an implant removed, the site regrafted, made whole, and new implants placed. So Sam and I have talked over the years about this failure rate of 3 to 5% that we see published. And having placed over 30,000 implants myself, and I think I have around 1,600 of these type of cases, I've decided it's pretty tough to define failure. We have aesthetic failures that are fully functional. We have functional failures, obviously, where we have pain and mobility, and we have everything in between. I think failure depends on who's defining it, and what's a failure to a patient in the aesthetic zone with just a little tissue discoloration. We might look at a radiograph and say this is amazing, but to our patient that paid $10,000 for the case and doesn't like the outcome, this can be problematic. So this is an older implant, cement retained, and you'll notice the contours of the crown and the defect. This is a case the dentist called me and said, Todd, I can't cut this crown off. First of all, I got to go through so much metal. I don't know where the crown metal will stop, the abutment metal will begin, the implant collar will begin. There's no way I can see. If I cut this off, we're essentially dooming the implant. You're going to have to cut it out. So this is a case where you have to work around the implant, and I don't know any instrument that will get here other than a laser, because I've tried everything. You cannot positive pressure force acid etch into here or antibiotic sluices. You cannot get curettes in here. I think your best chance would be an implantectomy and grind all these threads off, but even that is tough in that mesial space with a handpiece and a burr. You're doing it by feel. The laser, I think, gives us the best chance. So this is a typical case I do with what I call a mini flap. So I'll make a little intrasulcular incision, and I'll reflect down beyond the mucogingival junction. And if I need a releasing incision, I'll do that. And you'll see a case later on here today where I sometimes do that. But the laser is able to circumferentially go around this implant quite well. I'm confident in the detoxification. And then often I will graft using DFDBA right through that sulcular incision I've made. And this is what the case looked like 6 months later, probing 4 millimeters. We have a happy patient, but what we really have is a happy dentist. If you can get your referring base some cases that are successful, you'll notice your floodgates open, and they'll send you all kinds of things you can't save. But still, they turn into cases that you can redo. They also start having great faith in your implant placement. When they send you their sick implants, you're able to fix them or even prolong them for 5 years. It's a huge success for the dentists. Guess who they ask to place their implant cases? So this is just a typical example of a run-of-the-mill day-to-day case that I try and save. Sam, you can pull the next one. Yeah, so this is a similar case too. I grabbed this one mostly for the contour of the crown. If you look at this in your mind's eye in the mouth, you know how hard it is to instrument the distal of that implant in the contact area. Difficult to see. Posterior mouth, sometimes they don't have the biggest openings. What instrument are you going to get in there to debride the distal part of that implant? A scaler, a curette, a file. If you're going to do it with chemotherapeutics, how can you get your sluice into that space and be confident it's reaching the apex? I really don't think you can, but the laser gives you confidence. And again, it's the only reason I bought this laser in the beginning was for these peri-implantitis cases. I've since expanded to using it in almost all of my perio cases and some soft tissue work, but always on my implant cases. Never do I do an implant repair without the laser. Sam, let's see the next one. So kind of expanding on that big crown or the cemented restoration that the dentist is loath to cut through. Those are very unpleasant cases if you've ever cut a crown off an implant. It ruins your dentist's day. But even worse are the implants part of a fixed partial denture. So when you've got 3 or 4 or 5 units on a implant supported prosthesis and one of the implants is failing, boy, that's a tough conversation to tell your patient, we've got to take your bridge off, trephine out this posterior implant graft, new implant, and they all say the same thing, but doc, can I use my bridge again? And of course they cannot. When we add up the cost to replace this, it's astronomical and typically a barrier for my patient base in Arizona. Most people kind of broke the bank to get the original treatment, and they are anticipating it will last for life. So imagine when your dentist calls you and says, doctor, you got to help me save this implant. I'm looking at a big refund for this patient, or I've got to redo the case for free, or I'm dealing with a very angry patient. You got to pull me out of the fire. So it's difficult to work under these conditions with a bridge, and these are not easy, but with a laser, you have a good chance of detoxifying these very tricky defects. And here's a case I think that was a success. It was also probing 4 millimeters after 6 months. The patient's symptoms were gone. The dentist was very happy. I'll typically keep these patients in my maintenance pool once we've done these cases. We will recommend they get them cleaned 4 times a year, alternating with me and their GP. That way I can keep an eye on how things are going. I don't typically overpromise, but I'll tell patients, look, if we can get this thing healthy, detoxified, and I can give you 5 more years with this, we're going to count that a home run. You start putting some money in the bank in case this needs to be replaced. And I never have patients get upset with that. They understand the limitations, but I think we can get them more than the 5 years. But it's my practice to kind of promise what we have a good chance to deliver and not promise too much. Sam, let's see our next one. So look, I like anterior cases better. We can see them better. Typically the implant platform is a lesser diameter. But what you want to think about, or at least what I think about in anterior cases is, okay, if I have to trephine this out, let's say we're not successful saving this. Let me think about the aesthetic defect. And let's talk again about that aesthetic failure versus functional failure. Can we trephine this out, graft that defect back to par with soft tissue, place a new implant and a new restoration that's going to satisfy an aesthetic zone patient? I submit that's pretty tricky to do. So if we can save these anterior implants, which typically have good gingival architecture, we still have full papilla. We typically have good gingival margins, and if they happen to have a big display when they smile, these are not cases you want to trephine out. If you can avoid it, you'll find it's tricky to get back the aesthetics you want. So the laser gives us a chance, in my opinion, which again is the only reason I bought this, and I'm not a paid employee of BioLase. I would have bought anything that would have fixed implants, but to my knowledge, it was then and still is the only instrument I can use around a failing implant, it gives me a reasonable chance of success because I've tried all the other things that Sam showed, and there's not another laser we can put on these multiple implant surfaces. Personally, I've had quite good luck. I'd have to go through my cases and figure out how many are successes. For my happy patients and happy GPs, we're way over 50%. We don't save all the cases we do. We save more than we lose. But again, it depends on if we're defining functional and aesthetic successes. I do have implant cases with the collars showing that are now healthy and the patients are very happy. But if we publish that in a magazine, most folks would say, well, that's a failure, Todd. We can see the collar. And that's true. They have a point. But if my patients are happy, and most importantly, my GP referring docs are happy, that I'm calling a success. And we can do a lot of good in that area. Sam, let's see our next one. So I picked this implant mostly for the surface. You'll recognize this is Nobel Active. Very aggressive thread pitch, as Sam calls it. And what you'll notice, you probably already have, is many of the all-on 4, 5, and 6 cases that we do across the country employ this implant. And I can't tell you how many all-on 6 cases I have flapped with 1 or 2 of the implants failing. And this is a tricky implant surface. If you can put a curette on that, if you think you can force EDTA in all those spaces confidently, be my guest. I don't know how you clean this surface without light. It's the only thing that ever did make sense to me. And so while this is a single crown case, more often with Nobel Active, I see them underneath all-on 4s, 5s, and 6s. And typically on those cases, I'll remove the prosthesis, flap the area, debride this particular implant surface with the laser, graft it with a membrane. I'll close it all up, and then I'll put their prosthesis back on, which thrills the patient. They really don't want to go home in a denture, and they don't want to go home with nothing. And we have had many, many, many cases regenerate. But I thought this was a good one to show even the trickiest surface, which I think Nobel Active presents the trickiest surface for us. We can get really pretty spectacular results. I wish I could flap these, Sam, and give you guys a peek at the bone. It doesn't really work like that very often. I'd have to have a really good reason to go in. So all I can offer are radiographs. And typical with many patients, they do disappear from hygiene again. Once they're healthy and their symptoms are gone, pretty soon they skip a year. I have a lot of snowbird patients, and that's 6 months out of town when they come back. Don't quite get on track. So I don't get to keep my arms around everybody, but I think you would agree this is a pretty good success, and aesthetically the gingiva really never changed. All right, Sam, what's next? So this is a case similar to the one Sam showed from Dr. Chang. Straumann tissue level, wide neck. It's a tricky space to get into these interproximal areas. And I think the etiology of these cases is important. It's probably hygiene combined with food impaction. And not all of my patients are great at returning to their dentists for cleanings until they pay me a bunch of money to fix their implant. And I tell them how important the maintenance phase is. They get religion and they typically get better. But I don't know how you would treat this case, once again, without the laser. How are you going to get 3 millimeters subgingival and 6 millimeters subcrestal circumferentially in a contact space with any instrument that I can think of? And again, I tried them all. I've even broken tips off of scalers in the old days. And now you got to go fishing for a scalar tip. And I've lost the head off a burr as I'm doing an implantectomy. I've had to take radiographs and go find my burr head because it's somewhere in there. I think the laser gives us a really good advantage just from access. If the only thing the laser gave us was that tip Sam described and the access to contact these surfaces, that would be worth it. But the physics and chemistry and other things the laser gives us, and again, I'm no paid shill for BioLase. I'm just a guy who's trying to fix sick implants, and I need the best armamentarium I can have, and I need successes. So if your referring docs send you a couple of cases, you charge their patient and there's not a good outcome. That's reality. It can happen, but they're not going to send many more. I think they'll give you a few tries and then they'll just simply assume a failing implant cannot be rescued. But you save a few of these. And I would recommend keeping radiographic records just to show your GPs and your patients, because they'll come back years later, maybe having issues, but you can show them their befores and afters. You can show the GPs, which I'll typically send them an email at their 6-month post-op with the before and after. And I get accolades I don't deserve. I get much appreciation from my dentists, but if you don't take some records, make a tiny bit of effort, it's hard to remember your successes. But I'll tell you this, after you have a few, the dentists will, they'll have confidence in you for a long, long time. And when you have cases that don't work out too well, they'll understand, yeah, you don't bat 1,000 with this, but I know Dr. Smith in Kentucky, he does a great job, and I've seen him save these. And Sam is right. This is a big revenue stream for us periodontists. And I've noticed even my oral surgeon friends with whom I compete for many of the placement cases, they get along quite well with me and say, Todd, I got this all on 6. It was a blank of a case. We're a few years in, I'm losing some bone. Can you help me out? And they'll come in, I'll take the prosthesis off, flap, graft, and I'll typically do a soft tissue graft on the buccal. As we all know, those tissues thin over the years. And if you want to make an oral surgeon grateful to you, you've got some huge favors in the bank for when you have a case not go well and need a colleague to help you out. But I've noticed we've formed a pretty good referral pattern where the competition barriers have kind of come down, and we're doing more of what I call kind of co-opetition. We cooperate and compete, but I've got more cases than I can do. I'm booked out farther than is probably reasonable. And even with 2 associates, we could work 7 days a week, really, and not have much downtime. I have noticed a big increase in patient bases just from fixing sick implants. And I love to catch them there. So here's an odd one. I saw this case come in, and this patient had the implant for a number of years and just total apical blowout. I had my endo friends take a look at it, not related to the adjacent teeth. I don't know that we ever discovered what caused this infection, but the reason I wanted to show this, I think most of us would say, yeah, this is a failed case. We've got to, the coronal 3rd or 4th of this implant that's integrated. It looks scary. Let's get this out. But again, think about the aesthetics you're going to leave yourself with if you trephine this out, put them in a temporary for a number of months, 6 to 9 probably, and try to build them back. But even more importantly, think about how are you going to instrument the apex of this implant? What file is going to fit in there or curette? How would you apply EDTA or antibiotic solutions to the palatal surface of this apex? I can't think of a way to do it. Are you going to flap this on the palate clear to the mid suture? And you'll probably have to go 3 teeth in both directions to get visibility. I used the laser to detoxify this. I grafted it with DFDBA, and this was the case 6 months later. This is now many years old. This patient is in perfect condition. I only wish I knew what caused it. I never figured out what caused this blowout, but very, very happy patient. And the general dentists that refer this to you, when it works out well, they think you're a miracle worker. They'll start sending you all kinds of stuff. If you can bring this back from the dead, they'll have high confidence in you for many things, including just perio, basic old school perio. What we got next, Sam? Just a different implant surface here. Again, we've got a case that the patient, and this one was unique because this patient was 89 years old, had significant neurological deficit, was basically non-functioning without their children helping them. At least ASA class 3, maybe 4, on so many medications, including blood thinners. I thought, I cannot even flap this guy in an outpatient setting and be comfortable, let alone trephine this thing out. I think this would be a hospital case just based on this patient's ASA. So the dentist calls me up, said, Todd, I don't know what to do. There's suppuration, there's an infection. This guy is 89 and in very poor health. What can we do? And so I did this case totally flapless. Just put a laser in the sulcus and debrided it circumferentially. You can tell his restorations are pretty old. Contact open there on the posterior, but that's not really key, too significant given this patient's health. And then I grafted right through the sulcus with a little bit of DFDBA mixed with Emdogain because I just did not want to see this guy with an infection. I didn't want to see him back in the office. I didn't think I could really flap him and do a more invasive surgery safely, and nor did I want to. But to send this guy to the hospital, to my surgery friends with privileges, I don't know what the price tag would be. And what we're doing to an 89-year-old fellow that he doesn't know where he is or what day it is, what a service we can provide. I just did a little local, right? Just infiltrated right at the gingival margin, probably 1/10 of a carpule, and just blanched the tissue, put the laser tip in there, flushed everything out, cleaned it, put a little bone mixed with Emdogain, and here he was 6 months later. And this case made me almost as happy as any case, just because I saved this guy from a lot of heartache and potentially a risky procedure. And we all have patients in that category where we just don't want to shoot them full of anesthetic and flap them, expose the bone and risk infection. And do you want to put this guy on antibiotics for 10 days, given all of the meds he's on? We didn't want to. So this was a really conservative case that probably took me 15 minutes, and love the results. So sometimes you get these results and you feel really good. We'll just finish here. I'll do 2 minutes. Sam showed some great cases. I didn't know what he would have today, but you'll take a radiograph sometimes and it will look like you just have a little bit of bone loss on the mesial. It doesn't look too bad. And lots of dentists will just take some bite wings during their typical exams, maybe miss the probing, but you really got this going on. And once there's suppuration or some odor, and there's some more clues, then all of a sudden they get the patient over to you. So this is one I had to flap. You're looking at 12 to 15 millimeter defect. That's the laser in action, pretty poor photography. This was a long time ago. It's cleaned, it's grafted, it's closed up, and occasionally I do have to flap and really get in there. Most of the time I don't. I do them right through the sulcus, and the surgeries are very low level, low impact or non-invasive almost. But sometimes you do this, and this patient still got her implant 9 years later. And again, you look like a hero to your GPs, but I'll give the credit to BioLays, the scientists that gave us this instrument. I don't think if it was not in my arsenal, I would take on most of these cases. But with it in my arsenal, I take on most of them, and we do see a lot of good results. Sam, that's probably enough for me, right? We want to do a few questions?
Sure. So Joe, do you want me to do the questions, or do you want to?
Well, let me see, Dr. Lau.
I see we've got a few.
I'm happy to moderate these, Dr. Lau
Okay.
and Dr. Todd. So let me go through some of them. So question number 1, is the corrosion in implants coming from the titanium itself or from other metals in the titanium alloy?
I can answer that. It's actually, when you get osseointegration, what occurs is there is a bond that where the titanium or titanium alloy itself releases titanium oxide and helps create the bond. And so that's why you really do not have a direct ankylosis with osteointegration. However, over time, the theory is this, that the microflora possibly can create some type of physiologic environment. It could be acidic, etc. in which we're starting to then have these implants corrode. And as they corrode, they release they have a titanium oxide naturally on the surface, but now you don't have bone on it. So until you remove the titanium oxide from the surface and get the surface almost back to where it came out of the package, you're not going to get osseointegration. And that's what most of the Japanese professionals have been able to demonstrate to us. So it's actually coming from the titanium itself. And you can see these titanium oxide particulates. And Tom Wilson in in Texas has demonstrated this, that you'll see these titanium oxide particulates and then this huge giant cell reaction around them. So until you, what we call detoxify, and so that's what I get a little concerned when we talk about detoxifying strictly from an antimicrobial standpoint. I think you're detoxifying not only from an antimicrobial standpoint, but also from a surface standpoint, in which we call that metallosis.
Got it. Thank you. Try to challenge you there with the first question, Dr. Lau. Next question, I believe this is one of your cases, Dr. Jorgenson. So I'll read it verbatim here. On the odd periapical case, how did you get the laser behind it on the palatal?
So I just did, obviously on that one, I had to flap from the buccal. And I just took an elevator and I went around the circumference of the apex of that implant and pushed into the palatal soft tissue. There was no bone. And all I did was create enough space for my laser. And then palatally, just a circular incision, you'll take an elevator or just some kind of release instrument and make just enough room for the tip of your laser to get to the apex of that implant and just go circumferentially around it that way. But I didn't have to flap the palate other than that circular incision and a little bit of release on that coronal bone. And so there's some faith that my light is getting where it needs to get. But that case was easier than it looked.
Got it. Thank you. There were a couple questions about, I think there was some curiosity around what type of membrane and bone that you use or recommend. Do you have any recommendations?
So I typically use DFDBA only, and for membranes, any of the resorbable collagen membranes I think are sufficient. I typically like resorbable, so I don't have to go back in. I do sometimes do non-resorbable with titanium reinforcement. If I've got a one-wall defect or I'm getting some lateral augmentation that's significant, I'll put a couple of tenting screws in. Those cases are rare. Typically, it's just resorbable membranes. On the buccal, just my own personal philosophy, again, having done over 30,000 and seen, I don't really know how many I've seen. It's incredibly common we get thinning of the buccal tissue over these implants as the years go on. I just tuck a piece of alloderm in there all the time, and I don't even necessarily have to always charge for it. But if I'm in there and I have gone in from the facial, they're almost always getting some alloderm. It's super low impact, and you know, we're giving them 5 more years of attached tissue probably. But as you do this longer and longer, you'll notice every X number of years, 5 to 10, you might want to get a little tissue in there. I think our mucositis starts with that thinning of the tissues. And I don't know why it does it mostly only on the buccal, but we see it. So you can use alloderm as your membrane if the defect presents that way. And oftentimes that's what I do too.
Thank you. Next one that I'll read. Given the info that you shared about the implant surface and potential risk for metal corrosion, could you share what implant type or brands that you recommend to use?
Are they asking for placement in the cases I place?
I think that's the direction they're headed, is if for based off of what you see in the implant surface and the risk for metal corrosion, do you recommend any type of implant or brand to place at the forefront?
That's probably more for Sam. I think there are many good implant systems, and I place 4 typically. My personal favorite, if we're just talking shop, around some coffees, I'm going to tell you the Straumann with the SL Active Surface I really like. Most of my implants are Straumann. If I have referring docs with really strong allegiance to Nobel and 3i, I do place a significant number of both of those. For whatever reason, in my own hands, I just have great luck with Straumann. It's hard for me to gauge my success rates because, like I said, what do you determine is a failure? Aesthetic versus functional, but I do not see a lot of Straumann implants fail. So I love them. I have more failures with 3i and Nobel, but I don't want to get in trouble with them. I know amazing surgeons who are the opposite. They love Nobel or 3i and have Straumann as their second or third. But my favorite is Straumann.
Yeah, and I'm with Todd. We don't want to be, discussing brands. I would probably more likely discuss the surface. I do think that the anodized surfaces are probably more vulnerable. It was, as I mentioned before, it's the devil in the deep blue sea. They're very nice for osteointegration, but if you do get osseous resorption, they're generally the first to go. We also don't, though, and I can tell you this from the research that we've done, is that if you're going to use laser on a surface, you do need to be careful with anodized, with Nobel. And the reason for that is that, it's sort of like a laminate. And if water gets behind that laminate, between the titanium surface and the laminate, then it'll actually, like the laminate, will peel off. So if you are a waterless user, please don't ever go over the 1.5 to 2 watts that we recommend for the side firing tip, or it will delaminate on the anodized surface. But for me personally, I'm a Straumann person. I've always been a Straumann. To me, it's almost industrial strength, even with the bone level. So that would be my choice.
Yeah, thank you all for addressing that. As we wrap up, there were a couple last questions just about video content as far as the protocol that both of you referenced, and where to find additional resources about the protocol that both of you referenced. Good time for me to pivot to our education website here and review that with the audience for the last 60 seconds or so that we're on together. Before I do, for the most part, I feel like we've addressed the majority of the questions that were given to us. So I thank the audience for taking time to post their questions in the Q&A and joining us tonight. Definitely am grateful and appreciate the case presentation by Dr. Jorgenson. Dr. Jorgenson, you probably were focused on your presentation and didn't see, but a lot of positive comments in the chat box about your beautiful cases that you showed and great before and after. So a lot of positive comments there. And of course, as always, Dr. Lau, it's great to have you with us, and great content that you shared with us. As we wrap up, just wanted to point our audience to our website, education.biolase.com. Now, when you go to this website or biolase.com, there's an education tab at the top of the page. So if you joined us tonight, hopefully you learned something new. And if you're intrigued about the peri-implantitis protocol with the erbium chromium YSGG laser, the implant repair protocol, you can go to this education website. You can view webinars like this. So you can view our webinar library. You can also look up and find animation videos about our implant repair protocol, the content that we reviewed tonight. So I encourage you to go there and check that out. I'll also point the audience to our Waterlays Academy, which is kind of our home base for all things education with the erbium chromium YSGG Waterlays laser. That's where you'll find courses. So all sorts of things, but you'll find courses there. If you want to join us for one of our foundational courses, you can read our learning objectives, and you can find our courses on that website, waterlaysacademy.com. And you can also find a listing of our advanced courses. Now, these are, hence the name, advanced courses. You have to be a current user and have already some use and training behind you. But to join these courses, we have all sorts lined up for you to pick from. And two that I wanted to highlight before we wrap up. First one coming up on August 19th. That's with Dr. Lau here. He's going to be instructing out in the BioLays Education Center in Southern California, a new training facility that we have on aesthetics. And that's going to be everything from clinical crown lengthening to gum depigmentation to even fractional skin resurfacing with this wavelength. So if that intrigues you, please join us, and you can find information on our Waterlays Academy and Education website and register for that course. And hey, since we're talking about implants, I did want to give you information on Dr. Paul Chang's course coming up on September 8th. Dr. Lau showed one of his cases, and he practices in McKinney, Texas, right outside of DFW. And he will be hosting this course on September 8th in his practice. He has a nice training facility there, and he'll be instructing an all-day course on this topic. Like I mentioned, we have recorded tonight's session. We'll edit it and put it into our webinar library for you to watch as many times as you would like, and look for our other webinar content in our webinar library at biolays.com/webinars. And then if you have any questions for us, our team is here to help. education@biolays.com is the email address. You can shoot us a message and we'll be sure to respond to you. So again, Dr. Jorgenson, Dr. Lau, time's up here. It went by very fast because it was such a great session, great content. Appreciate y'all joining us. And to our audience, thank you for joining us. And I hope you have a great rest of your evening or day, wherever you may be. So take care. Thank you.